So, and now we have three very, very fascinating topics. We start first with a biopsy. So some of you might ask, so why is biopsy in an imaging course? But that's because, you know, one, biopsy is integral to, it has been for long the gold standard for giant cell arteritis, but it's also somehow an imaging. That was really the words of Alberto when he last time had his talk at the live meeting in Innsbruck, that also biopsy assessment is nothing else than imaging. And the question now to you is, Alberto, when should we still use temporal artery biopsy? We have all now these nice imaging machines, ultrasound, other techniques. What is still a place for biopsy?
Thanks, Christian. Thanks for this kind invitation. I'm happy to be here.
I forgot to introduce that you are from Reggio Emilia and that you are a pathologist, and that you have published a lot in the field of GCA, but also in other fields, and that you now will give the talk. So go ahead.
Thanks, Christian. Thanks, Christian. No, the question when to perform a biopsy or not is clearly a clinical decision. And in general, I think you clinician consider the possibility of a biopsy whenever your diagnostic confidence based on the non-invasive or less invasive data is not high enough to treat the patient. For example, in this setting, as we have seen, if there is a discrepancy between the echographic and the clinical data. In this brief talk, I will share with you some pathological considerations, which I hope can be of some help for you to take this decision. The classical hallmark of a positive temporal artery biopsy is transmural inflammation, consisting in a lymphohistiocytic inflammatory infiltrate involving the media of the temporal artery. Giant cells are present in about 70% of the cases, so sometimes they are absent and they are not necessary to make a diagnosis of giant cell arteritis. In about 20% of the cases, there is a peculiar laminar necrosis following the internal elastic lamina, which simulates fibrinoid necrosis, but it is not. A real fibrinoid necrosis, as we will see, is quite rare. Occasionally, there is an acute thrombosis, rarely many neutrophils, rarely many eosinophils. So the histology of transmural inflammation is quite variable, and several groups try to correlate this histologic variability with the clinical data, obtaining different results. I think these results are interesting on a scientific point of view, but probably are not so fundamental on a clinical point of view. So I think to detect the histologic variability of transmural inflammation is probably not a sufficient reason to perform a temporal artery biopsy. In about 20% of the inflamed biopsies, the inflammation does not involve the media, but it is restricted to adventitial and periadventitial tissues, sometimes forming small cuffing around the periadventitial small vessels, so-called small vessel vasculitis, sometimes around the vasa vasorum, intraadventitial vasa vasorum, so-called vasa vasorum vasculitis, and sometimes involving more extensively the media, but again without extension into the media. Involving adventitia without extension into the media. These are very subtle histologic findings, so not surprisingly, echography has a low sensitivity to detect them. And the question clearly is, what is the clinical significance of these mild inflammatory lesions? This is a recent study from our group, and I think the main result is this one. The predictive value of inflammation restricted to adventitial and periadventitial tissue for a clinical diagnosis of giant cell arteritis, independently of the way in which it is obtained, is low. Not different, statistically not different from a negative temporal artery biopsy. And this result is confirmed in a couple of other recent studies. Probably inflammation limited to adventitia is more significant than vasa vasorum vasculitis and small vessel vasculitis, but the data are not enough, I think. So for the moment, I think to detect inflammation restricted to adventitial periadventitial tissue probably is not a sufficient reason to perform a temporal artery biopsy. This is an incomplete list of disease which occasionally can be different from giant cell arteritis, which occasionally can be diagnosed on temporal artery biopsy. Regarding in particular other vasculitis, there are some histologic findings which are quite unusual in giant cell arteritis, so their presence increase the probability of a different vasculitis. In particular, there are fibrinoid necrosis, inflammation restricted to periadventitial small vessels or small branches, like here. The artery, temporal artery is spared, but here I don't see very well, but here there is a mild inflammation around a small branch. A small branch is simply a small vessel with a muscular coat. And just these histologic findings increases a little bit the probability of a vasculitis different from giant cell arteritis. This patient had an ANCA-associated vasculitis. And also many neutrophils or eosinophils are unusual. This is an example, a biopsy showing a transmural inflammation composed mostly of eosinophils. A finding rising the possibility of an allergic reaction or a Church-Strauss or something like that. But clinically, this patient had a classical giant cell arteritis. And this example reminds us that none of these findings exclude per se giant cell arteritis. Simply to find some of these findings increase the probability of a different vasculitis. So these are just pieces of information for the clinician. So I think to detect a disease different from giant cell arteritis may be a reason to perform a temporal artery biopsy in selected patients. This is a small series of 40 patients with giant cell arteritis treated with steroids with a first positive temporal biopsy and a second biopsy obtained at different times, at different months after starting of the therapy. And these are the results. And the point is that vasculitis tends to decrease with time, but is still present in a significant proportion of patients, even several months after steroid therapy. So the sensitivity to steroid therapy of histology is lower than the sensitivity of steroid therapy of the clinical data, of the clinical and the echographic data. So a previous steroid treatment may be a reason to perform a temporal artery biopsy in selected patients, clearly when there is a need of a diagnosis and the ecography is negative. This temporal artery biopsy has a very high specificity. We may discuss about this 100%. I don't believe very much in 100% in general, but and the variable sensitivity. So whenever the decision to take a biopsy has been taken, to obtain a biopsy has been taken, then we have to consider to take care of several conditions which may increase the sensitivity of the technique. First of all, the correct clinical selection of the patients, including a biopsy performed possibly not too far from the starting of steroid therapy. It is important that biopsy has to be of a high quality, and that means a few artifacts, spacement, prefixation length of at least 7-10 millimeters, selection of the site of the biopsy based on clinical finding, and bilateral biopsies just in selected patients. Equally important is the meticulous evaluation by the pathologist. We routinely obtain three recuts at different levels in all our negative temporal artery biopsies, and in this way we observed 6.4% of biopsies that initially were negative becoming inflamed. In the majority of these cases, inflammation was restricted to adventitial, periadventitial tissues, as we have seen, probably of low clinical significance, and just in a minority of these cases, a negative biopsy became a transmural inflammation, so a significant transmural inflammation in the recuts. And last but not least, fundamental is a good communication between clinician and pathologist. And that, I think, is all, and I thank you for your attention.
So, but maybe if I could start, Alberto. So, one question I had is, would it make sense to do first an ultrasound and then when you find a suspicious error to ask the surgeon or whoever is doing the biopsy exactly to take the sample from there? Would that help, or would you just take a random sample from somewhere?
I don't know. There is data, for what I know, the data from a study from Giuseppe Germanò from our group. And if I'm correct, in this study, adding ultrasound to decide the exact position of the biopsy did not increase the sensitivity of the biopsy compared to our clinical evaluation, so the evaluation of the most involved sites and the that is so. I think our rheumatologist, I'm not sure what they do, honestly. So I don't know. The data I know is from that paper from Giuseppe Germanò. I don't know if there are other data.
Well, let's ask the other people from the faculty. So Wolfgang, Bhaskar, Stavros, Andreas, could you come back, please? Switch on the camera and probably comment on this topic, because I think that's very interesting. Or Christina is the first. Christina, well, maybe you would like to answer. So are you doing, so when you ask for a biopsy, are you doing first, or I'm doing first the ultrasound and mark it? And my second part of the question, how many biopsies do you still perform?
So I'm not doing an ultrasound guided biopsy, because if I do an ultrasound and I find a thickness that is a halo, I usually, depending on the clinical probability, I usually stay with that and don't need biopsy. Only if I have doubt and it's just a localized part of the artery, then I go for biopsy. What Alberto is saying is that study from his center actually also didn't perform well by choosing just on the symptoms. If you just choose to do a biopsy based on right or left, because you have more headache on the right or more headache on the left, or either by guided ultrasound, was exactly the same. So it also shows that it doesn't increase much more the sensitivity. I only do biopsy and those places where I see the ultrasound and there is the thickening, which I'm not very comfortable in saying no, but also not very comfortable in saying yes. But that is rare. In my center, we just do 1 or 2 biopsies per year, I would say.
Okay, so very rarely, but I think that's a very, very good point that you make. So another indication really for biopsies, when the ultrasound or the imaging result is not clear. So when you are unsure whether it's really vasculitis or Kimura disease or Lewis or something else. So when the ultrasound result is not clear, that's probably another good, that's a good indication for biopsy. But probably then it would be, so at least in my view, to do an ultrasound guided biopsy, because then you would like to mark where you have the uncertainty. So when everything is negative and you have only a small segment that is suspicious, then probably you would like to biopsy out exactly that specimen. Would you agree on that?
Yes, yeah, I usually just write on the frontal branch or parietal branch, things like that, right or left, yeah. But it's true, because if you apply the score that Bhaskar is saying, if you have a lot of arteries that are inflamed, and it depends on what you're seeing, why are you going for biopsy? It's just like, yeah, just those parts that have doubts, that we have doubts, particularly when there are patients treated with steroids for many months or things like that, but they're still not sure. Yeah.
Okay. Okay, so the others from the faculty still seem to have coffee, but maybe Alberto, I would have a specific comment, a specific question concerning the reliability. I announced it already during the talk from Stavros. So, and also having heard your talk, what are the possible features that could link to another disease, but could then still be present in GCA patients, and all the challenges with the right length and doing the meticulous analysis. So what is your feeling? Is really histology something that is clearly objective, or are there also some problems with reliability?
No, it is interesting, because my main field of interest is interstitial lung disease. And several years ago, histology was considered the absolute gold standard for the diagnosis. Then it appeared a few papers that showed that interpersonal agreement between expert pathologists was moderate, particularly in difficult cases. And that created a disaster among pulmonologists. Before we were heroes, and then we became something that useless, absolutely. In reality, the fact that we pathologists know that we disagree among us every day, basically. So it is a normal thing for us. And the reality is not exactly that we are not heroes and we are not a disaster. We are something in the middle. I think in this topic in particular, the scientific data on interpersonal agreement are not many. My impression is that we agree quite well in the easiest cases, so in the diagnosis of transmural inflammation. I think we probably have a good agreement. Where we disagree, it is in the gray areas, so in the mildest inflammatory lesions, and in these cases our agreement is lower. But in the classical cases, I suspect that our agreement is quite high. But I'm not sure the scientific data are strong enough on this topic.
Well, I think, but that would also be true for imaging. When you have very clear-cut cases, I think the agreement is very high. It's always the gray cases where it's challenging. Maybe another interesting thing to note at this point is that the difference between the EULA and the ACR recommendations. So the EULA recommendations for management, not only for imaging, they say that imaging would be the first line test, and whereas the ACR recommendations say that still biopsy would be the first line test. And the reasoning behind this, that ACR says that in the US, there are not so many people well trained in ultrasound that they cannot recommend it as a first test. So that means they trust a lot in the pathologists, or they simply move the responsibility away from them and to the pathologists. So
yes.
That's very interesting. Are there some questions in the meantime in the chat?
Yeah, there are.
That's great. So people, please ask. So you have the experts here. You have now the chance to make your questions.
But it is still a question regarding the ultrasound probe. Is possibly Christina, the question was what is the optimal ultrasound probe, the recommended ultrasound probe for performing ultrasound in the case of suspicion of GCA?
We cannot hear you, Christina.
Sorry. Yeah, sorry. So going back
It's
to
the hocus pocus probe, isn't it? It's the hocus pocus probe from Valentin.
Oh, yeah, you should use that one. But actually, we said in the recommendations, EULA recommendations, that we advise to at least use a probe that is 15 megahertz or higher. Actually, the probe from Valentin is 10 megahertz, but of course, it's not only the megahertz that counts, also the quality of the images that has to do with a lot of other physical parameters. So what we would advise is having a probe that is 15 megahertz or above, like those acoustic probes, things like that. We now use, our group uses, for instance, between 15, mostly between 18 and 24 megahertz. There are now probes with 55 megahertz that you can see everything, even the adventitia, the medium, all those differences. And there are some published papers in Finland over those probes with higher sensitivity, but it's still not a reality in many of the European centers and in American centers as well. So I would advise 15 megahertz, but also because it's a recommendation, but also it depends on the quality of the ultrasound you use.
Okay.
There's no other question in the chat, but I have another question to Alberto. And this is, you mentioned that it makes sense in selected cases to do or perform a bilateral biopsy of the temporal arteries. Could you please clarify what is really the situation? When should we think about a bilateral biopsy of the temporal arteries?
Thanks for the question. No, again, I think it is clearly a clinical decision, and in our group, I think our rheumatologists do very rarely. We have very few bilateral temporal artery biopsies, and I think that the cases in which the first biopsy was negative, but the clinical suspicion that was so high, and they decided to do a second biopsy from the contralateral biopsy. And in our, I don't remember exactly the numbers, but in our few cases, the second biopsy was quite frequently positive, but they were just very selected patients. I don't know what is your point, but I think the general recommendation is to do first a unilateral biopsy and to reserve a contralateral biopsy just in very selected cases, I think.
Yeah, I totally agree with your opinion that this only holds true for very, very selected cases, and most frequently it should be done unilaterally. There's another question regarding the performance of the biopsy. Who should be the specialist performing the biopsy? And again, what are the risks? Possibly all other experts are invited to answer this question.
Yes, for what I know, I think in general, in our hospital, there was a period in which it was a dermatologist, in another period an ocular specialist who did the biopsy. So I think in general is the person who knows to do the biopsy, and that's for what I know, the complications are very low, but I probably I'm not the best people to ask for that. It is but
I can help with that. So if you see the TABOO study, which recruited around 400 patients, the complications were below 1%. Some of them were like pain in the place where you took out the biopsy specimen and paresthesia. But if you look at the literature, there are complications, particularly when only biopsies were being done, like the facial nerve involvement. If you take the biopsy and cut the facial nerve, that's, I think, the most spoken complications in the literature. There are some very rare, like scalp necrosis, but that is very, very rare. That's why usually, and you can comment on that, Alberto, you usually ask to take either the frontal or the parietal, not the common superficial, because you would be more prone to having necrosis because you would have less collateral arteries. I don't know if you want to comment on that, but that's the data basically.
Thanks.
So probably the rheumatologist should do the biopsy. So when I hear that the dermatologist actually is doing the biopsy, then why should not we do the biopsy? That would be, actually, there are some people who are doing it. Maria Cid, for example, from Spain, she's doing the biopsy herself. That would be probably something for the practical skills at the EULVIC meeting when we are in presence. So if there are some volunteers where we can cut out the temporal artery biopsy, we could practice a little bit. Or we could maybe take Valentine's model from the gilet, and then we took it out from the gilet.
And I could do a frozen section of the biopsy.
That would be fantastic. So we have some ice cream as well.